This is the session about exercise rehabilitation in patients with cardiovascular diseases. I'm honored. My name is Samah Shaheen. I'm honored to be a chairperson or co-chairperson in this session. With me is Professor Ghada Slim from Ain Shams, Professor Hussam Hassan from Asyut, Professor Khalid Al-Maghrabi from Minya, Professor Nasser Taha from Minya, Professor Wala Adil from Ain Shams, and Professor Yasser Hosni from Banha. Four eminent speakers about the subject. Let me introduce the first speaker. Professor Adil Shabana is one of the eminent figures in cardiac rehabilitation and one of the founders of cardiac rehabilitation in Ain Shams University Cardiology Department. He will talk about which exercise is possible in hypertensive patients. Professor Adil.
Okay. Thank you, Mr. Chairman, and thanks to the organizing committee for inviting me for this elegant conference. My subject is exercise prescription in hypertensive patients. So, first, hypertension is a major modifiable risk factor for cardiovascular disease. Its prevalence is increasing, of course, because of sedentary life, obesity, and stress contributes to such increase. Forward. Okay, I will just talk quickly about the effect of exercise on blood pressure. So normally, exercise session will increase the blood pressure around 10 millimeter mercury for each MET achieved, mainly in the systolic blood pressure. But some people may develop exaggerated blood pressure response for several mechanisms which are associated with this increase, which is about more than 60 millimeter mercury in men or 50 millimeter mercury in women above the baseline. متابعين أوي. نعم. يعني أعمل إيه؟
Until we adjust the slides, I think I have to announce again that this is a conjoint symposium or session with the European Association of Preventive Cardiology. And we are honored to have one of the members of this association with us in this panel, Professor Anna Abru. He is the president-elect, she is the president-elect of the association from Portugal. We'll be hearing from her.
Thank you, sir. So I will continue that some of the patients or some of the people may develop post-exercise hypotensive response, which may last for almost a whole 24 hours. But chronic training or chronic physiological response by regular training will finally end by reducing the blood pressure, so it is very effective in people with hypertension. Hypertensive people, it is quite evident that hypertensive people will benefit from regular exercise. The programs now includes endurance activity, resistance training, or both. And we can see from this figure that aerobic exercise and resistance exercise, or both together, can help in reducing the blood pressure, systolic and diastolic blood pressure, and even ambulatory blood pressure numbers. And this benefit is not only regulating the blood pressure, but also it will help in improving the general health, cardiovascular health and stress reduction. We need to agree about some issues which have been in some argument about this. First, exercise effects are not inferior to antihypertensive treatment effects. From a large meta-analysis 3 years ago, it was quite evident that exercise and medicine, each one of them alone can reduce blood pressure nearly the same. And doing exercise regularly in patients on antihypertensive medications will help or potentiate the blood pressure effects of these medications. The second thing, which maybe we are not using in our country, is the neuromotor exercises, which are like yoga or tai chi. These neuromotor exercises have been found to produce significant blood pressure responses, even in some studies or some meta-analysis more than aerobic and resistance exercises. The third issue is that exercise is mostly safe in hypertensive patients. Although we know that strenuous physical activity may produce arrhythmias, it may induce some kind of myocardial ischemia or infarction in some individuals, but in general, if we adequately select the patients and we did risk stratification, we can avoid these events. The last thing is that exercise is also beneficial in resistant hypertension. We have new data from two important meta-analyses and trials, Triumph trial and Enrich trial. Both were produced in 2021, and they concluded that exercise alone may elicit greater blood pressure reductions than medications alone, and when combined, the antihypertensive effects are greater than medication alone in treatment of resistant hypertension. So, what kind of exercises we will do for hypertensive patients? What is agreed upon from many guidelines is that we do aerobic exercises, endurance exercises, and the dynamic resistance exercises in addition to flexibility exercise. In all of these, we do what is known as the FIT principle. This is a detailed one about how to use each modality of exercise. And there is some difference between the American and European guidelines regarding the isometric resistance exercise, because the American Sport Association, ACSM, did not recommend isometric resistance exercise training like hand grip, but the European Association of Preventive Cardiology, in a consensus document, they said as a second line, we can use resistance training, whether isometric or dynamic, can be used as a second line therapy in patients with hypertension. But still, of course, the first line is aerobic exercise training. We do have special considerations in patients with hypertension. For example, those on significant doses of beta blockers and diuretics. This may induce hypoglycemia in diabetic patients. It may impair the body temperature regulation during exercise. Also, sometimes beta blocker will affect the maximum exercise capacity, which a patient can do. Some of the antihypertensive drugs may induce hypotensive and may prolong the post-exercise hypotensive response, especially if you did not do an adequate cool-down period. And if the patient is hypertensive and ischemic, we have to be sure that we are almost 10 beats below the anginal threshold of this patient. In some patients who are severely hypertensive or uncontrolled, we have to clear them first before doing exercise for them. Finally, we have to tailor the program for the individual by individualized approach, gradual progression in the intensity and the duration of exercise, and monitoring the response of this patient to exercise. And of course, it is better if we add to exercise therapy, dietary consideration, stress management, behavioral support, and of course, the best is cardiac rehabilitation program if it is available. Thank you.
Thank you very much, Professor Adel. I have one or two questions maybe to start discussing this important item. If you have a hypertensive patient, are you permitted as a cardiologist to prescribe exercise for your hypertensive patients, or you should advise him to join one of the cardiac rehabilitation programs. Because I'm asking whether is it safe for this patient to go, for example, if he's asking me to go for a gym to play some weightlifting or something like this, or it should be under the supervision of a cardiac rehabilitation team. What's the practice for a hypertensive patient in this regard?
Okay, if hypertension is controlled already with medications, patient is not ischemic, is not a high-risk patient, he can do it by himself. No need to monitor or to clear him from cardiac rehabilitation team or something like that. But in order to prescribe exercise, it's better first to prescribe aerobic exercise, not weightlifting. So the recommendation is aerobic exercise, and then we can add dynamic resistance exercise, gradually increasing, and then later on he can do some kind of isometric, like weightlifting, taking care that he is not doing Valsalva during this exercise.
Which level of blood pressure that is safe to prescribe this exercise? Or because you mentioned that even resistant hypertensive patients are allowed to do exercise. So is there a level, a cutoff point above which it's not recommended to do an exercise for a hypertensive patient?
I didn't find a certain level, but if the response is very high with exercise, he has to stop. We have some blood pressure levels you cannot go more in exercise. So, but I don't know if there is, because
so
this
be cautious in this regard.
I mean, the people with resistant exercise in these studies, they are already on 3 or 4 medications, and still they are not controlled, and they did exercise for them. But you have to monitor the patient that he will not develop a big hypertensive response. Dr. Yasser, you have a comment?
Yeah, thank you very much, Professor Adel, for this presentation. Actually, I have 2 comments. The first regarding the incorporation of isometric exercises, mainly weightlifting. Usually we start, like you said, with the aerobic exercises, what they call the cardio exercises. And later on, you could also incorporate the use of isometric exercise. We start with 40% of the RM. The RM is the maximum repetition that could be lifted in one movement. By using the 40%, we don't allow the player to have Valsalva, and there is no negative effects from the training itself. Regarding the cutoff level of the blood pressure, it's the same cutoff level that we use in stress testing. It's the 200 millimeter, the systolic blood pressure. Thank you.
Thank you, Dr. S. Yes, the problem is in the resistance exercise, because doing isometric resistance, if the patient is not advised not to do Valsalva, this will be very dangerous because it will provoke hypertensive response. So it's important to advise the patient not to do Valsalva during weightlifting. Thank you.
Now we shift to the next speaker, Dr. Ghada Slim, Professor of Cardiology at Shams University. She will present us a lecture topic of exercise in heart failure, when and how.
Hello, everyone. Excuse my cold. So I'd like to start by thanking the Cardiology Department of Asyut and Minya Universities for the invitation. It's a pleasure to be here. So we'll be talking today about exercise for heart failure, when and how. Heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. Exercise intolerance, chronic fatigue, and dyspnea are cardinal manifestations of heart failure and associated with poor quality of life and adverse outcomes. So if we look at the causes of exercise intolerance in heart failure, we'll find that there are central cardiac mechanisms and there are peripheral mechanisms. Central cardiac mechanisms are mainly due to the inadequate cardiac output and high LV filling pressures, which lead to pulmonary vascular remodeling and impaired gas exchange. Also, the inadequate cardiac output leads to early anaerobic metabolism at the muscle, and so muscle fatigue and alterations at the structural level of muscle fibers. Peripheral mechanisms include endothelial dysfunction, vasoconstriction, obesity, sympathetic and inflammatory overstimulation. So Contrary to the general belief, exercise is associated with a wide range of benefits for patients of heart failure. Exercise is known to be positive inotropic, lusitropic, which speaks of relaxation, negative chronotropic. It improves the stroke volume and filling pressures. It's diuretic, antihypertensive, hypoglycemic, lipid lowering, and weight reducing. It's also anti-inflammatory, antidepressive, and hypnotic. It also causes improvement in vasomotor, endothelial, and skeletal muscle function. So independent of the LV functions, patients who will perform better on the exercise will have better quality of life and lower mortality and hospitalization rates. And that's why the 2016 ESC guidelines for diagnosis and treatment of heart failure established cardiac rehab as class 1 level of evidence A for treating patients with heart failure. Regular aerobic exercise is encouraged in patients with heart failure to improve functional capacity and symptoms. Supervised exercise training is recommended for stable, and by stable they mean who have not had recent, less than 6 weeks, or planned less than six months major cardiovascular hospitalization or procedure. Stable patients with NIHA class 1 to 3, and it should be initiated after initiating medical therapy for heart failure has been optimized, so after optimal medical treatment. So what is cardiac rehab? It's a multidisciplinary preventive program where exercise training is a pillar alongside lifestyle modification and psychological intervention, and they lead to improvements in exercise capacity, quality of life, psychological well-being, and reductions in hospital admissions. In terms of exercise capacity and quality of life, a meta-analysis of 29 randomized controlled trials showed that 848 patients revealed a mean improvement of peak oxygen consumption of 13%. And we know that any small changes in the peak oxygen consumption leads to significant improved outcomes. Another meta-analysis showed significant improvement in the quality of life. In terms of hospitalization and mortality, we have one of the earliest and largest trials, the Heart Failure Action, which is a randomized controlled trial that included 2,331 patients with HFrEF, and it randomized patients to either supervised aerobic exercise training at moderate intensity or the usual care. And they showed a reduction of 25% in overall hospitalization and 39% reduction in heart failure-specific hospitalization. Another Cochrane review of exercise training included 33 trials, showed a reduction in mortality at around 1 year follow-up. So 2022 AHA guidelines recommend exercise as one of the lifestyle modification for stage A across all the spectrum of heart failure. So stage A, which are the patients who are at risk for heart failure, stage B, who are the pre-heart failure, and stage C, as we discussed, NIHA class 1, 2, and 3. There's no evidence to support the benefits of exercise training for NIHA class 4. So while many drugs have failed to achieve benefit in HFpEF, exercise training has shown consistent benefit in patients with HFpEF because of its effect on the cardiac output and the skeletal muscles. So before we send the patients to exercise, we first do a pre-exercise testing to determine the risk, to determine if the patient can exercise safely, and then we repeat it after the program to evaluate the improvements. Normally, we evaluate the NIHA classification, and then we send the patient to do a submaximal exercise testing, symptom limited, whether cardiopulmonary or modified Norton protocol. And we can also do a 6-minute walk. And this is the formula that we use to prescribe the test. And here you can see that we obtain the maximum heart rate from the exercise testing. We subtract from it the resting heart rate, and then we multiply it by the training rate. So say we want to exercise the patient at 50 to 60%. So say that the maximum heart rate is 170. We subtract from it the 70, which is the resting heart rate, and we multiply by 50 or 60, which is the training percentage. And then we add again the resting heart rate. So we obtain 120 to 130. This would be his exercise training heart range. And this we will monitor that his exercise does not exceed this range. We also teach the patient the modified Borg scale, which is a subjective perception of the intensity of the exercise. We encourage the patient to exercise at Borg scale 9, which is very hard activity, so that the patient can barely breathe or speak a single word. Of course, there are contraindications for exercise training, such as uncontrolled life-threatening cardiac arrhythmias, acute heart failure, high-degree AV block, acute myocarditis and pericarditis, symptomatic LVOT obstruction, progressive worsening of heart failure symptoms in the previous 3 to 5 days, NIHA class 4, significant myocardial ischemia or arrhythmia during the low-intensity exercise, and of course, any uncontrolled medical condition. So it's best to initiate cardiac rehab in a structured, supervised, center-based program, such as a hospital, and closely supervise and monitor heart rate and blood pressure. Most programs offer 8 to 12 weeks training, and then they gradually transition to a home-based program, whether with telemonitoring or without. So there's a variety of exercise protocols for heart failure that vary according to intensity, type, and method. We're going to take a look at some of them. The aerobic or endurance training is the main one. And as you see here, patients exercise 20 minutes, and you can increase gradually to 60 minutes, at least 3 to 5 days. And they start at 40% of peak oxygen consumption, progressing to 50, 65, sometimes 70% of peak oxygen consumption, or using the Covenant formula as we explained. And the exercise type here is treadmill, biking, or jogging. And we monitor the intensity, the heart rate, and the Borg scale. And it has been shown to reverse left ventricular remodeling in patients with heart failure. The advantage of this is that we can obtain some information from the patient's training regarding their METs achievement, and we can counsel them to safe levels of exercise, whether in jobs or in sports. Then we have the resistance training, which the patient can start after 4 weeks of tolerated exercise. And the session is about 20 to 30 minutes. The patient can start with 10 repetitions of less than 30 repetition max, and increase gradually to 8 to 15 repetitions of 40 to 60% repetition max. This includes using bands, weight machines, and handheld machines. And it's good to exercise because it increases the muscle and bone mass, and it helps the patients with their daily activities, and so improves the quality of life. And there's a high-intensity interval training where the patient performs short bouts of moderate to high-intensity exercise, alternating with longer recovery phases at low or no workload. It's a safe exercise, and the studies show that it's either superior or similar to moderate intensity continuous training in improving aerobic capacity, heart rate, blood pressure, LV ejection fraction, and biomarkers. This is the inspiratory muscle training. I will skip that. Then there's special consideration. So every time we see the patient, we have to assess for the fluid retention, pulmonary peripheral congestion, weight gain, cachexia, as well as frailty. And frailty is an important topic in heart failure because 50% of heart failure patients are frail, according to TopCat study. So frail describes the inability of the patients to gain homeostasis after a life-threatening event. It's basically their fragility or their vulnerability. It's a major predictor of mortality, and it's associated with 65% increased risk of hospitalization. And there are multiple tools to assess frailty. One of them is the Fright tool, where we look at the patient's muscle grip using a dynamometer, and we measure the walking speed. They should walk 5 meters in 5 seconds or more than 5 meters. And then there's self-reporting of the levels of physical activity and fatigue, and unintentional weight loss of more than 4.5 kilograms over a year. And you can see the Fright tool is dividing the score, whether frail or pre-frail or robust. Unfortunately, the management of frailty is also cardiac rehab, where the patient is encouraged to eat a diverse diet with vegetables and proteins, and to do more strengthening exercise, and to educate him about avoiding falls. Regarding CRT and ICD, exercise training in patients with ICD is safe. It's not associated with any increased risk of shocks. We sometimes recommend to stay below 10 to 20 beats below the firing threshold of the ICD. And if there's any impaired chronotropic response, we ask the patient to monitor their Borg or their perceived exertion levels. So we are proud that our cardiac rehab program at Ain Shams, which started in 2011, is listed on the European Society of Cardiology as one of the most comprehensive programs alongside Netherlands and Italy. And it's also listed to follow the European Society guidelines. So to wrap up, cardiac rehabilitation is a class 1A in treatment of heart failure. Exercise training is indicated for stable heart failure patients near class 1 to 3 on optimal medical treatment. It is safe. It has exercise capacity, quality of life, morbidity and mortality benefits. Moderate intensity continuous training, as well as high intensity training and resistance training are effective and safe. Exercise pre-testing and prescription are required. We start at a center-based and transition to home-based exercise training. Thank you very much for your attention.
Thank you, Dr. Ghada. Very nice presentation, elegant as usual. I just want to ask you if there is any additional data about heart failure with preserved ejection fraction and not reduced ejection fraction.
For now, what we know from the studies is that it is safe and it's effective. It improves the aerobic capacity, the exercise capacity, and improves the quality of life.
Okay, any questions? From...
Thank you, Dr. Ghada. And now we'll move to the next speaker, Professor Anna Ebro, Professor of Cardiology. She's the President-elect of the European Association of Preventive Cardiology.
Okay.
She will speak about how to implement available imaging modalities in rehabilitation programs.
Okay. It's okay? Okay. Thank you very much. Thank you very much for the very kind invitation. It's a pleasure to be here in this joint session. And I think the previous speakers said a lot about rehabilitation, and I have my work facilitated. That's okay. So let's see how to implement available imaging modalities in these programs. I'm not saying exactly the same as my previous colleague said. Everybody knows what is cardiovascular rehabilitation, and surely it's not only exercise, despite the importance of this component. The benefits were already said, they are a lot. It is an intervention cost effective, which is very important. And I am very proud to say that my center, which performs the several phases of rehabilitation, is accredited by the European Society of Cardiology because it fulfills the criteria for the minimal standards and some optimal standards. So we have phase 1 with all the components, and the phase 3, which is a maintenance phase. We have now 140 patients in program continuously, and we are gathering more patients. We have also workshops for all these patients, which are regularly performed. And the problem was that we had everything very well arranged, but then in 2020, we had the problem of social isolation due to COVID pandemic. So we thought, what about now? Patients start calling and saying they were afraid, they could not exercise anymore, what should they do? So we had all these challenges because of not being able to do it center-based. We have already a lot of barriers. We know that lots of people who should do rehabilitation, they don't do it for multiple reasons, but then we had one more reason, COVID pandemic. And the consequences of physical inactivity and social isolation are a lot, not only cardiovascular, but for other chronic diseases, and especially for mental disease, which was very unstable during and after this period. But how to maintain patients in a program at distance? So we know, and we looked to a lot of types of home-based cardiac rehabilitation. We know that we can do rehabilitation at home without imaging, without looking at the patient. Like, for instance, in United Kingdom, they have the program with a heart manual for lung, where patients take a book to the home and they do themselves. But of course, we have different severity risk, different patients that some we have to monitor, and we were thinking how to do this. How could that be possible in a very short time? Because we had no time to think a lot. So we created a platform which is called Rec Home, in Portuguese, Rec Casa. And in this platform, through it, we could do several things. We could do exercise in the center with our exercise physiologists and our physiotherapists, and then the patients would be at home. By Zoom, we were connected. We could see them doing exercise, and they could see us performing exercise and adjusting what they were doing. They were taught how to self-monitor heart rate, blood pressure, symptoms. They knew how to use the Borg scale. So we could do this very easily and very promptly with the same human resources and with the same financial support. So we start almost immediately after 3 weeks of social isolation. These sessions were done exactly the same as in physical presence, center-based, with the same periods of time, with the same thing. The issue was that we had the patients already evaluated because they were already integrated in the program. So it was easier. We had the exercise testing results, but we did a questionnaire by Google Forms. We performed a filling questionnaire to evaluate the stability of the patients by that time to make sure they were not incurring more risks. So we had a lot of educative sessions online, PowerPoints, we video recorded, and we had also online workshops, talks with the heart, and relaxation sessions performed by a yoga teacher. Then we published our results. We evaluated physical activity at 3 months and at 1 year, and also we evaluated a lot of secondary purposes, as you see, and the results were very good. They improved physical activity, which was moderate to vigorous. They decreased the sedentary time, and we had a weight maintenance in these patients. You might think, okay, they did not reduce weight if they were overweight or obese, but the question was that during COVID, people increased weight because they were more sedentary, they were eating more sweets, they were very, very anxious. So it was a good result to maintain the weight. After this, at the EAPC Congress, we attended a lot of papers regarding telerehabilitation and home-based during COVID. As you can see, I have here some examples, and it was understood that people tried to arrange phone consults, telerehabilitation videos, tools of education material in the web, and telesessions as we performed for exercise and physical activity counseling. So we performed this paper at our association saying exactly that people should be creative. We should be doing things that could be practical, that could be effective. So there was a lot of telephone and video consultation, text messaging, social media was also used, and we need really to be inventing new things and to support this type of rehabilitation at distance. The last Cochrane home-based versus center-based cardiac rehabilitation supports the good results and the good benefits of home-based as center-based if the patients are correctly evaluated, as previous Cochrane, which was performed some years before. However, home-based has not only advantages, we have also problems. The advantages for patients who prefer more privacy at their own place, their own time, protection from infections, tailoring at possible, low cost. But then we have the problem of digital illiteracy. Not everybody has the digital means. We have the problem of reimbursement, less face-to-face real interaction, and lack of social interaction among the patients between them because they like that. We also have in our center-based center dinners and actions, cultural actions, where everybody's going with the family, and that is really good. So what we need now to face is really the problem of digital illiteracy. And we continue after COVID with home-based for those who want it. And we have something that I consider very useful, which is hybrid programs. They are evaluated at the center, they start at the center, they continue at home, they can come to the center to refresh, and that is very useful. So it is really necessary is to develop programs at home with the same quality as center-based programs. And we have now a lot of possibilities for remote monitoring, a lot of devices. We have the smartwatch, the smartphone, the patches, the pedometers, wearable sensors. So we can not only monitor exercise through different ways, but also monitor the weight, the diet, blood pressure control, smoking cessation or not, diabetes control, and the psychosocial issues, which are really quite important in cardiovascular patients. So there are also now systems which already analyze the exercise of the patient at home, which was prescribed. And with the progression of patients, they automatically compare these results with database results, and they adjust automatically the exercise prescription, helping physiotherapists and doctors, and so being able to expand to more patients, which are increasing every day. So I advise you to see this paper of American Heart Association on digital technologies in cardiac rehabilitation. Here you have a lot of definitions about home-based, digital rehabilitation, telerehabilitation, because not everything is the same. This is a big bag from very simple to very complex and still in development. And it is important to understand that we have 3 different types of cardiac rehabilitation at distance using telemedicine. We have the synchronous in-person here with the patient and the with the patient and the clinician in the same place, but using digital technology. We have upper synchronous real-time audiovisual, which is virtual because the patient is at home, but he's being monitored. And then we have remote asynchronous, which means that the patient exercises independently and posteriorly the clinician reviews data and provides feedback. So we have to recognize all the potentials of digital health, but at the same time, the disparities, the challenges, implement solutions, develop and implement structured and systematic systems, look at those patients who cannot be left behind due to the lack of digital means and digital literacy, and establish an action plan to address the new inequities and biases. I present you here the future, which is an European study with a lot of countries. It is based in Finland, and it is the core of prevention. It is a very large European multi-center study based on personalized prevention using digital tools, which go to exercise, nutrition, pharmacological adherence, education, and much more, covering all the main components of cardiac rehabilitation in physical presence. So, to finish my talk, I would say that the recent studies on telemanagement and telerehabilitation confirm it is effective, with better functional capacity, better quality of life, and also antiarrhythmic effects. It is safe, well tolerated, with a high adherence associated to prognostic improvement in adherent patients, of course, and of course, it is cost effective. So we still have a great potential of development, and a lot of people is really working on this. So thank you very much for your attention. These are some of our patients, and I invite you all to be present at our EAPC Preventive Cardiology Congress 24 in Athens, where we will talk a lot about telerehabilitation. Thank you very much.
Thank you very much, Prof. Anna. I'm happy to join you in 3 sessions together. I ask you what mode of rehabilitation in heart failure, in acute coronary syndrome, and time and mode of rehabilitation in different.
I didn't understand.
Yes.
So only the last part.
Rehabilitation in after acute coronary syndrome and rehabilitation
heart failure?
in heart failure.
Okay.
The mode and time.
The time.
Yes.
Okay. We have the majority of our patients are coronary patients, mostly after acute coronary syndrome, as happened in many centers. But we have now a greater amount of patients of heart failure, mainly with reduced ejection fraction and mainly with devices, ICDs and CRTs, and the protocols are a little different, meaning that heart failure patients, we perform longer programs. We try to have them more time because usually they have worse physical capacity. They need to train more muscle and the cardiovascular system. But that depends because we also have after acute coronary syndrome patients who have bad function or who are elderly or who are not used to exercise and are frail, as my colleague showed. So depending not only from the diagnosis, but mainly from the physical and psychological condition of the patient, we tailor our programs and we try to do at least 3 months for after coronary syndrome, and we try to go from 3 to 6 months in heart failure patients, but that is adjusted individually to each patient. We do aerobic, we do resistance, dynamic, of course, and we do inspiratory training, especially for heart failure or for those patients who also have respiratory disease added to cardiovascular disease.
Professor Abro, thank you very much. I really enjoyed the idea of tele-rehabilitation, something which is very innovative, and I think it can be applied in many countries, even in our country. I think it's nowadays with all these technologies. But my question is about how are you sure that you are properly monitoring your patient during exercise? Because we still are not very much confident in the smartphones, which is measuring, or the wearable devices, which is measuring the blood pressure, for example. So is it for you enough to monitor patients with cardiovascular disease to do exercise at home with such wearable devices?
Yeah, I understand. Thank you very much for your question. I can tell you that my experience is we use home-based tele-rehabilitation for those patients who are low risk or intermediate risk. Those who are at higher risk, we prefer to have them at the center. And mostly these, also in COVID, but mostly what we try to do is, even those who are doing at home, we try to start in the center, even if it is 1, 2, 3 sessions. So with that, we can be sure about the monitorization. We can teach them how to monitor. Many of them have smartwatches, but many of them also have monitors of blood pressure at home. They are very well trained to self-evaluate themselves. Of course, here we have the problem of those who have more illiteracy or who are older. We try to connect these patients with some family members, like, for instance, if it's sold, like somebody from the family who works better with a smartwatch or with a computer. So I think this is still a work in progress. We need to learn more, to do more, but our first evaluation of these 109 patients was really very good, and we had only one problem. One of the patients made a twist in the ankle. Only that problem. No cardiovascular problems during the 1 year. So thank you very much.
Thank you very much. Thank you. Now we transfer to another session. Prof. Martin Hallo, the president of the European Association of Preventive Cardiology. Yes, it is virtual online. Hello?
Can you hear me?
Hello, Dr. Martin.
Yes, can you hear me?
Welcome. We hear you.
Can you give?
Yes,
Okay, super good.
we're listening for
Thank
you. Yes.
Yeah, thank you very much for the
Welcome.
invitation. Yes, thank you very much. Sorry that I cannot be with you in Egypt. I will come very soon. So thanks very much. Anna, hello from my
Hello,
side.
hello.
And so it is great to be in this session. And I would like to talk about the implementation of artificial intelligence in cardiovascular prevention. Well, if we look at differences of people with different risk profile, it is important to become better in risk prediction. The risk prediction we currently do is we have risk assessment systems like the Framingham risk score or the global risk or the score in Europe. And the score risk assessment you are well aware of is the ESC score 2, also for older people, the OP, ESC score OP, and it includes age, sex, smoking status, in addition to blood pressure, HDL cholesterol, and can predict the 10-year cardiovascular risk. But even taking this into account, when we look at countries and regions with the same, and this is important, with the same risk assessment score, we apply, if we apply the score in different countries, we get different results. So there is something beyond all these cardiovascular risk factors that we are aware of, and these are cultural and other issues, genetics, and so forth. Genetics, looking here at data from Brian Ferentz from Cambridge, looking at the polygenetic risk score at low, medium, and high risk. And this then in addition to LDL cholesterol and elevated systolic blood pressure. And you can see here that there is this difference taking also the genetics into account. But not only that, so we do have, when we apply diet, exercise intervention, also into the risk profile, we are currently really bad into this. What we know is that from the UK Biobank, looking at the genetic risk, if it's low, moderate, or high, certainly increasing from left to right. But looking then also at other parameters like physical fitness or maximal exercise capacity. So you can see here the difference, looking at high genetic score and high physical fitness, reducing then the score or the risk from about 2 to 2.5 to about to less than 1. So these lifestyle factors do also have an effect on the cardiovascular risk. And then also, when we look at change in peak VO2, so this exercise capacity over 3 months in a trial which we have done in our department, and these stripes are individuals. So these are 300 individuals, and then when you see you have change in peak VO2, despite the fact that they train, you have reductions in peak VO2 in those who train. And then in others, you have significant improvements in VO2. So there's a wide variety of response to exercise intervention as just one preventive intervention that to look at. And when it comes to endurance training and responders versus non-responders, and looking at the extracellular space, plasma membrane, and cytoplasm as compartments, for example, of the muscle, then you can see here that there's significant difference in the high responder versus low responder regarding these training interventions. So people are different, responses are different, and when we look at the cardiovascular disease risk or then disease manifestation, we have the non-responders, we have the responders to exercise, also nutritional aspects, and we have the super responders that will reach age of 100, even if they just do very little from a preventive aspect. So this is the scenario. And what I would like to highlight here is that we have a lot more data available from pathophysiology, so biomarkers. We have a lot of data from genomics. We have a lot of data from imaging, whether it's cardiovascular imaging, like here, coronary calcium and CT scans, or whether it's intravascular ultrasound and others, just give examples. So we are in the phase that we have a lot more information to be included. So data acquisition, for example, including artificial intelligence, is looking at the biomarker profiling, then sensors for microRNAs, and sensors for antibodies, sensors for peptides, protein measurements, sweat and saliva, heart rates, and in a lot of other directions, sensors are developed. Also adding then to biomarker profiling, which is not only at rest, but also looking at profile during exercise challenge, for example. How do inflammatory markers, for example, from resting to maximal exercise, how do they change? And what does really change? What has changed during the day when you look at sensors and sensor data acquisition? What about all the wearables we have? Like this is this is located at the eye, so this is just an eye sensor. Then this is on the skin, as outlined here. Implantable wearables are on the market, or are on the edge on the market. And when we look at data analysis and integration, all the Apple Watches and all we need for this. It's great, it's fantastic, but to analyze all the data, we do need artificial intelligence. So all this taking together, then a longitudinal follow-up, personalized target blood tests every 6 months, for example. Also then applying personalized targeting biometric monitoring into all these data housing. And when we do have this, then this is applied to an iPhone, and then the individual, based on all this, will then be led to more on diet, more on exercise, more in intensity of exercise, more other factors that are individualized when it comes to personalized prevention. Just an example from a initiative we are currently doing here at Technical University. So if we look at healthy individuals, those at high risk and cardiac events, this is about 30 to 40 years. So early onwards of cardiovascular risk assessment is important, and then looking at the cardiovascular events and rehab as outlined by Anna. So this is the current trajectory, what we are currently doing. But what we should be doing is that we introduce, in addition, epigenetic profiling in addition to cardiovascular risk assessment just by blood assessment. Then we need continuous biometric monitoring at different stages of changing from healthy to high risk and cardiac event patients. Then also a continuous biometric monitoring once the acute cardiovascular event has been taken place, and then also in the post-acute phase during rehab, and these data then into artificial intelligence engine, and then information to be processed to improve primary prevention, primordial prevention, primary prevention, and secondary prevention. So I think AI is particularly on the edge in cardiology when it comes to prevention, and I think we should get started, but the future is today. Thank you very much.
Thank you very much for your nice presentation. Any question?
Yeah, thank you very much. I think this is a dream to have all this information for such patients to predict the outcome of this patient, to prescribe the proper exercise modality for this patient based on information that we are having from artificial intelligence. I just want to get some information from you. What's your team consisting of? Cardiologists, those in computer skills? How can you integrate all this information into a clinical reliable system? So I just want to know from your center, from your experience.
Yes, the point here is that it's very, very important that you align the physicians, doctors, with all those mathematicians, AI experts, statistics experts, and sensor technology. They don't have a clue on anything. So it is on anything regarding medicine. So I think that is very, very important. We here at TUM, we do have this all in place here. There has been a huge initiative on professorships only in Bavaria, hundreds of professors for appointment on AI, and about 20 in AI and medicine. So there is a huge initiative here that also then includes sensor technology people to be included into the team. And it is the physicians, the databases that we need. So what we definitely need is structured databases and online sensors that online give information continuously. So what we do not just need is like we had in epidemiology, the database. 1,000, 5,000, 10,000 individuals, assessed, and then we wait until they have a cardiovascular event. This is history. So what we need is a continuous monitoring, and these data then being processed and looking into into cardiac events. I'm absolutely convinced that this is the future for Google and Apple, because they do have these data, and people will enter their own cholesterol levels and their own whatever they'll go to. Like if they go to Egypt and have a different pollution level, sunshine, and ozone, and other parameters. This is also then from the weather app included into all this. So it will be completely different. Like HDL cholesterol, LDL cholesterol, blood pressure. This is really history. It is currently present, and we work okay with it, but there is a lot more to be developed.
Such an amazing future. I think we are expecting a lot from artificial intelligence. Thank you very much, and hope you all the best in your project. Thank you very much.
Thank you also.